want to thank Jordan for the invitation. It's a great honor to be here. The primary purpose of my trip to Toronto is to encourage you all to think about whether this model is effective for Canada. So I'm going to ask you this question in the end. I'm giving you advance warnings so you can think about the answer to this question. The mission of Project ECHO is to expand the capacity to provide best practice care for common complex diseases in rural and underserved areas and to monitor outcomes. You've already heard about hepatitis C as a global health problem. The bigger problem is that about 20 million people will die from this disease over the next 25 years if we don't do what the previous speaker has talked about. And it's not just Canada. We have to do something all over the world. It's not acceptable that 20 million people will die because the drugs have been priced out of reach for most of the populations of the world. So in New Mexico, where I live, there are 28,000 people who had this disease in 2004. Now it's 35,000. There were 2,300 prisoners who had been diagnosed. None had been treated, despite the fact the law exists. It was the highest rate of chronic liver disease and cirrhosis in the country. And the good news was that it's curable. The bad news is there are many, many side effects. Now we're talking about 2004, interferon side effects of anemia, neutropenia, depression. And as a result, not a single primary care doctor in New Mexico was treating hepatitis C in 2004. I'm a hepatologist at the University of New Mexico, and I run a hepatitis C clinic. And people were trying to come to see me from all parts of New Mexico. There was an 8-month wait to see me. My understanding is there are clinics of that kind even in Canada, where it takes 7-8 months to see a specialist. And people were driving hundreds of miles to see me. So if I was treating genotype 1 infection, somebody could take 12 to 18 trips each way, driving 200-300 miles for a course of treatment. And that just wasn't feasible if they were poor. The problem wasn't lack of medicines. In the United States, ever since I started treating hepatitis C in the early 90s, I really have never had a patient that I couldn't get the medicine for. 100% of patients could get medicine. Some through their insurance company, and if they had no insurance, we'd be able to get it from the pharmaceutical company for free. But that wasn't the problem. The problem was there was no capacity to treat the disease because there were few people who were treating it. New Mexico is rural. 32 of 33 counties are medically underserved. 14 are health professional shortage areas. And so we developed Project ECHO with two goals. First, we said we would develop the capacity to safely and effectively treat hepatitis C in all areas of New Mexico and to monitor outcomes. And I hear from the previous speaker that would be a good goal for Canada right now. And second, we knew that if we could treat a complex disease with interferon ribavirin all over New Mexico, then we would have a model to treat complex diseases in rural locations and other developing countries. The first step in ECHO is a collaboration. We developed a partnership between the university, corrections, health, Indian Health Service, community health centers, etc. So I'm also going to take a stab at my opinion on that debate that's going to occur in the end. And that I don't think it's specialist or primary care doctors, specialists and primary care doctors. And that's what I'm going to try and show you how that could occur. So now the challenge was, how do we treat everybody who wants treatment in New Mexico? So we developed the model. It has based on 4 key principles. So if you have remembered one slide in this presentation, this is the one to remember. The first is we use technology, multi-point video conferencing, and the internet to leverage scarce resources. What were the scarce resources to treat hepatitis C? I needed a pharmacist, I needed a psychiatrist, and a liver specialist. So we said we would leverage the expertise of the university using technology. The second key idea in Project ECHO is a disease management model. Disease management is based on the work of Edward Deming. Many, many decades ago, Edward Deming went to the US automobile industry and told them, I'm going to teach you how to make better cars. And they told them, you know, we have 95% of the market. This is Ford, Chrysler, General Motors. And we don't need any help with quality. Our quality is great. So he actually left the United States and went and worked for Toyota Corporation. And the rest, is history. So I think that his insights came back to the United States as total quality management. In medicine, we call it disease management. But the idea is that if you want to get good outcomes, you want to create best practice and then standardize across your manufacturing sites. In our case, we want to standardize across the treatment sites. So because there was such a long wait, and New Mexico is such a large state, we set up 21 treatment sites for hepatitis C everywhere in New Mexico. 16 were in large community clinics, and 5 were in prisons, basically. So we had these 21 sites, and we said we were going to make these centers of excellence for treating hepatitis C. Each of these was run by a primary care doctor or a nurse practitioner or a physician assistant. That was the leader of this primary care site or the prison site. That brings us to the third point, is case-based learning. So we had this best practice protocol of treating hepatitis C. It was the AASLD guidelines, would be similar to the Canadian Association guidelines. We shared them. But how are we going to make a primary care doctor who's never gone to fellowship, how are we going to make him as good as a Jordan Feld in treating hepatitis C? I mean, that's the bottom line, right? You cannot have two standards of care. So we said we were going to use the same methodology how I became an expert in treating hepatitis C. We call it case-based learning. The way I like to explain that is whenever you want to do something complex, just giving people guidelines and lectures and reading books is not sufficient. So let me give you an example of what I mean by that. If you wanted to teach your daughter to drive a car, you couldn't just give her a few lectures and give her a manual, take a test, and then give her the keys to the car. How many would feel comfortable doing that? So what do you actually do when you want to teach your daughter to drive a car? You make her do all those other things, read the manual, but then you sit next to her and do what something is called guided practice. She drives the car under your supervision. Through that process of driving the car, she gains expertise gradually until she becomes expert, and then you let her go on her own. And that's really what we said we would do in ECHO. We would co-manage patients with the university specialists, so they would learn by doing rather than learn by just reading. And lastly, we said we would use a web-based database to track outcomes in all 21 sites simultaneously. So these are the 4 principles. We first published this in Academic Medicine in 2007. An important challenge comes up in ECHO is what really is best practice? Is it the AASLD guideline? Not really. Yes, in the Intel plant or the Toyota plant, the algorithm, the checklists all work. Algorithm is you treat for 6 months for genotype 2, 1 year for genotype 1. Checklists are that when a person comes for a 16-week visit to the University of Toronto, you do about 18 different things. You need to do a certain number of blood tests, physical exam. And if you just do it by memory, it's not going to work. You'll forget something. So you need checklists to do this. And you need process. That is, in my clinic, I can't do all these 18 things. I need the nurse to do some things, medical assistant to do something. All this has to come together in a best practice. This is exactly the same as a Toyota plant. There's one difference is in a Toyota assembly line, every car coming down the assembly line exactly the same. But in the assembly line in my clinic, the patients waiting for me, every patient is different by age, by sex, social factors, how far they live from work, what other comorbid illnesses do they have, how many other medicines do they take in addition to the interferon, ribavirin, protease inhibitor, etc. Do they have somebody to help them, remind them to take their medicines if they have cognitive impairment? So many variables. An expert, what he does is he modifies the guideline for the individual patient and creates. So therefore, the challenge for us to scale hepatitis C treatment in New Mexico wasn't just to scale the guideline. We have to scale the expertise of a super specialist. And that's what ECHO is designed to do. What are the steps? We train these physicians, mid-levels in hepatitis C. We train them on our software to track patient outcomes. And then we conduct these telemedicine clinics called knowledge networks. So this is what a knowledge network looks like. In the big, here, this is our team at the university: psychiatrist, liver specialist, and a pharmacist. Deb Newman from Espanola is presenting 1 or 2 patients of hepatitis C to us. She presents this patient along a standardized template. I need 20 pieces of information. She gives them all to me in about 4 or 5 minutes. Our team then gives her our opinion. Psychiatrist, pharmacist, we decide how to help her manage her patient. And we go to Las Cruces, then we go to Las Vegas, New Mexico. Over the course of about 2 hours, we'll co-manage about 12 patients of hepatitis C. We'll also give them a brief didactic presentation. We make a rule: we don't ever use more than 20 minutes of our 2 hours in a lecture. The rest is all case discussions, one after the other, which occur in de-identified ways. So everybody has an ECHO ID. We never say John Brown on the network. The way they become experts is called a learning loop. They learn from us through our advice, through our lectures. They learn from each other because they bring 1 or 2 patients to the network. They learn on 12 every week, but mostly they learn by doing. And that's what creates expertise, and we collect data. We give them no-cost continuing medical education credits, nursing credits. We want to give them professional interaction with colleagues of similar interests, so there's less isolation. In rural New Mexico, there's a high turnover because these doctors don't feel supported and mentored. And we feel we can do that by bringing a mix of work and learning and a community of practice and mentorship into their lives, and give them access to multiple specialists. The technologies are very commonplace. This is not a technology game. This is a collaborative practice game, basically. The technology, all you need is webcams now. Everybody has a webcam. We have in the cloud bridges that connect all these people simultaneously. And we have iHealth for disease management, and iEcho is our software to track program outcomes. We've done 500 such clinics. We've put 5,000 people into the disease management program, 52,000 hours of continuing medical education credit at no cost to these clinicians. So one of the challenges, of course, is whenever you have to do something complex, educational theory tells us that self-efficacy is one of the biggest predictors for success. If you believe, like I went to medical school and I went into the operating room and I saw a neurosurgeon work, and I said, look guys, no matter how much training you give me, I can't do this. That means I couldn't be a neurosurgeon on that day, basically. Self-efficacy is important. So we needed to study that. What's your ability to identify suitable candidates for treatment? These are primary care clinicians. Mean was 2.8 out of 7, where scale is 1, I have no skill. 7, I'm an expert who can teach others. Goes from 2.8 to 5.6 in 12 months. Very, very large effect sizes, 2.8. Generally, effect size of 0.8 is considered significant. What's your ability to treat and manage side effects? Goes from 2 to 5.2 in 12 months. Question number 5, can you now serve as a local consultant within your clinic in your area? There are about 3,000 doctors in New Mexico. We only put 21 sites. The question was 21 sites and 3,000 doctors. It would not have a huge impact except if these people were also accepting referrals from their colleagues in their local area. And they said they could do that, 2.4 to 5.6. Overall competence goes from 2.8 to 5.5. This is in September 2010 of hepatology. We wanted to understand, do these primary care clinicians find this beneficial to interact with the university professors? On the right, you'll see 97, 94, 98% of people feel that enhanced knowledge, being well informed and achieving competence was beneficial for them and their practice and how they thought of themselves. We then repeated this data for many, many diseases. And we found that and we published this in Health Affairs in 2011, June, which basically showed that no matter if we make a primary care doctor a rheumatology specialist or a hepatitis C expert, they're of course different doctors. They find that this is hugely beneficial for the way they think of themselves, and they like the idea of being mentored by university professors. Back to hepatitis C, Project ECHO has diminished my professional isolation, 4.3 out of 5. has enhanced my professional satisfaction, 4.8 out of 5. Collaboration is a benefit to my clinic, 4.9 out of 5. Expanded access to treatment in my area, 4.9 out of 5. Access in general to specialty expertise and consultation is a major area of need in my clinic, 4.9, etc. Finally, it's not enough for a doctor to enjoy himself and have high self-efficacy and be professionally satisfied. The real acid test is, can they do it as well as a specialist at the university? And these results were published in the New England Journal of Medicine in June of 2011. Our objectives were to train primary care clinicians in rural areas and prisons to show that such care is as safe and effective as a university clinic, and to improve care for minorities. In the United States, minorities have a much harder time accessing care for hepatitis C. We had 21 intervention sites, 16 community-based clinics, 5 prisons. Control was the University of New Mexico Liver Clinic. Every consecutive patient that met rigid exclusion-inclusion criteria. So what were the criteria? We used exactly the same criteria that the pharmaceutical companies had used to license these drugs. So we had some data to anchor our results. There was a prospective cohort study design. I won't go into the design in detail except to say that this design has a major limitation, that groups can be unbalanced with respect to patient covariates. It's the best we could do, because if you were living in 300 miles away, if you got randomized to the university, it would be very hard to get there. On the other hand, if you were living in the prison or if you were living in Albuquerque and you got randomized to the prison, that's were even harder to basically implement. We couldn't do a randomized control trial. Another possible randomized strategy was randomized doctors. Half of them get echo support, half get no support. And that our human research committee thought that was unethical, correctly so. How can you have a doctor treat hepatitis C without any training? So the best we could do is prospective cohort study, and the advantages of that are mentioned here. Prospective measurement of endpoints, etc. Principal endpoint was, as defined in the last talk, cure. Sustained viral response, no virus 6 months after completion of treatment. And as you saw in previous slides, this results in a 93% reduction in likelihood of liver failure over 10 years, JAMA in 2012, if you can cure even in patients with cirrhosis or advanced fibrosis. We enrolled 407 patients in this trial. These are the results. Minorities were 68% in echo, 49% university. Cure rate was 50, 46, 70, 71. Echo versus university. So we showed the hypothesis that they could do it as well under our mentorship. But a much more interesting finding emerged, and that is we found that the cure rate was higher than when private practice gastroenterologists or the prisons treat hepatitis C in New Mexico and in the United States overall. There was a trial in the VA, thousands of patients, their experience in 2009 hepatology, showing that their cure rate for genotype 1 was only 20%. And we said, wow, that was really low. Why is that? And we thought maybe the veterans are different. They were slightly older, but it just didn't make sense to have 20% cure rate in naive hepatitis C genotype 1. We looked at data within our trial, thousands of patients across the United States treated by private gastroenterologists. Cure rate for genotype 1 was 34%. Still lower. We think that treating a patient close to their home in a culturally appropriate setting, where they don't have to travel hundreds of miles, where you can get a multidisciplinary team approach, where a psychiatrist is also opining on the patient simultaneously, and a pharmacist is there, etc., you can get better care. Plus, the primary care site brings new knowledge to a specialist's input. Even a multidisciplinary team is not enough, because there are social, economic factors. These are the social determinants of disease and cure that also govern ability to cure and adhere to treatment. And the primary care site has more information. So that's what I was saying. Best practice is a very high standard. It's not just enough knowledge. It's all of these things coming together, and a knowledge network has the ability to do that. Our conclusions were that rural primary care clinicians deliver hepatitis C that is as safe and effective, and we can improve care for minorities. In November of 2013, we presented in Washington, D.C., showing that in 60% of patients, talking about the data previously presented, 60% of the patients, the treatment for hepatitis C was cost savings. That means the health system got paid to treat. Overall, when you include the other 40% where it actually cost us money for the cure, the overall cost per discounted quality of life year gained was $3,500. This is considered highly cost effective in the United States. In general, anything less than $50,000 per QALY is considered cost effective. After hepatitis C was successful, we described 6 criteria. We said the disease is common, management is complex, new treatments are coming, high societal impact, serious outcomes of untreated disease, and if you can improve outcomes with effective treatment, then you can use this model. You can see hepatitis C is highly applicable, but there are many other diseases like chronic pain, rheumatology, substance use disorders, mental health disorders, where you can use this model for effective treatment. Here, I want to show you Pareto's principle. It's the 80-20 rule. What we say here is a small number of diseases account for most of the morbidity, mortality. You don't need to do 200 echo projects in Canada. You can do 20 and you'll have massive improvements in healthcare costs and quality. And the second idea is we don't want to provide different care in Thunder Bay and different care in Toronto. Here we want to do is cut horizontally using technology, best practices, and case-based learning to provide the same level of care everywhere. The key goal of Project ECHO is force multiplier. This is a term I borrowed from the Department of Defense, where they use it for very much different purposes. I've redefined this term in healthcare as a logarithmic improvement in capacity to deliver best practice care. How do we do that? If you have a nurse practitioner, physician assistant, and primary care doctor providing the same level of care as a super specialist, then force multiplication occurs. These are all the different diseases where we have ECHO going on in New Mexico: hepatitis C, diabetes, endocrinology, geriatrics, palliative care, rheumatology, chronic pain, HIV, and so on. We have 400 points of contact all over New Mexico. Our vision is that in one area, this is called Carlsbad, New Mexico, we want at least one expert in rheumatology, one in HIV, one in hepatitis C, so they can create a self-sustaining network, but there aren't any specialists over there. This is our addictions mental health clinic. Only 32 of more than 3,000 doctors were certified by the federal government to prescribe a medicine called buprenorphine. This is a drug for people who are using opiates intravenously. This is all the sites that we've set up for addiction and mental health disorders. Red line is all the United States. On average, they have 15 doctors per million population that can prescribe this medicine in rural, low-income Hispanic neighborhoods. The blue line is New Mexico. We have 100 doctors now. The green vertical line is when ECHO starts. We use ECHO to train doctors to prescribe this medicine. Why do we think ECHO will be a useful modality for Canada? Firstly, it's rural area, very spread out, large surface area. Second, and patients are traveling long distances. But the biggest reason is because medical knowledge is increasing exponentially. I started the project in 2003, and then in 2011, May, everything I had taught them became obsolete because protease inhibitors came along. So I taught them again. Then now in December of 2013, again it became obsolete. Now I'm teaching them again. It's a constantly changing game, and a primary care doctor cannot keep up with this medical knowledge of every field, because the learning capacity of human beings is only going up in linear way. This is going up logarithmically. Actually, my learning capacity is going down like that. There's an increasing gap between what a doctor needs to know and what he can possibly learn. We are saying each doctor should choose a special area of interest, be mentored by a university like the University of Toronto or any other major, Queen's, any other university in Canada, so they can develop a special area of interest, be mentored, and do good for their community. The last 2 minutes, I'll talk about the idea that ECHO is not just to train doctors and nurse practitioners. We use it to train community health workers, medical assistants, nurses to become experts. They also join knowledge networks. Just to show you, when you add a community health worker to a team of a doctor, that team does twice as good in blood pressure, LDL, and smoking cessation. Why? Because these community health workers live in the community. They understand the culture. They appreciate economic limitations. They know the family, other resources they can bring to the table, but mostly they spend more time with the patient. In the United States, primary care doctors are seeing 30 patients, 25 patients in a day, and a obese patient walks in, they say, you got to lose weight, exercise 2 hours a week, eat more fruits and vegetables, stop smoking, I'll see you in 3 months. I mean, anybody who has kids knows that, for behavior change, you need hand-to-hand combat. It's not enough it's not enough to just fly over and drop some recommendations and hope they're going to stick. And so we have 4 training programs like this. We have our diabetes community health worker programs where we make them experts. We have our CARS program. These are community addiction recovery specialists. We have our multiple complex diagnosis and prison program. What is a typical program? This is a diabetes program. We take a community health worker, give them 3 days of on-site training, give them their webcams, then they join every week on their own knowledge networks, not doctor knowledge networks, but community health worker networks where they get more training on diet, exercise, smoking cessation, motivational interviewing, reminders, finger sticks, etc. We found, we checked everyone in the prison. We found 40% of our prisoners were positive for hepatitis C. And on our network, if you remember, there were 5 prisons joining us. They were presenting acute hepatitis C to me. And I said, wow, this is like swimming up the Niagara Falls. Yeah, because on one hand, I'm treating patients. On the other hand, they're getting acute infection in the prison. So we started to create a workforce in the prison. We have about 8,000 total prisoners in New Mexico. And what we said was we would train a workforce. We've trained 250 prisoners to become community health workers in the prison. They also come in on knowledge networks by video conference. You get more and more training. And in turn, they have trained 5,000 prisoners on how to prevent hepatitis C, sexually transmitted diseases, HIV, etc. This is their graduation ceremony. So the potential benefits of ECHO to the Canadian health system are improving quality and safety, rapid learning and best practice dissemination, reducing variation in care, improving access for underserved patients, workforce training, improving professional satisfaction, supporting the medical home model, cost-effective care by avoiding excessive testing. So, for example, the United States VA system spends $856 million every year just on transporting patients back and forth from rural areas to the veteran hospitals. In New Mexico, a Medicaid patient, the insurance company for the poor, pays $400 to a transportation company to bring the patient to see me, and then they'll give $100 to the specialist. So you can see the balance of where the money is being spent in terms. I know that you guys spend a lot of money here transporting patients by flight for specialty care, and that's not necessary. We want to prevent the cost of untreated disease. You saw some elegant slides of how much hepatitis C untreated is going to cost in the future unless you just let them die. And so why would all this occur? The core principle in ECHO is to demonopolize the knowledge of a super specialist and share it. And essentially, in the January issue of Academic Medicine, we've described a new vision and mission for academic centers all over the world. The title of the article is Demonopolizing Knowledge, where we say that the role of an academic medical center shouldn't just be train residents and fellows, send them home, and then compete with them. Instead, why should the academic medical center not take on the responsibility of lifelong learning for the entire workforce because of that knowledge curve by supporting them through knowledge networks? So that, and I encourage you to read that article if you are leading academic medical centers here. This is Albuquerque. This is our hepatitis C program all over New Mexico. This is a 400 points of contact all over New Mexico. These are all the universities in the United States that are replicating ECHO. University of Washington, Utah, Nevada, UCSF VA, University of Michigan, University of Chicago, Harvard, Beth Israel Deaconess Medical Center, etc. We have 30 hubs in the United States doing Project ECHO right now. These are all the different sites all over the United States that replicate ECHO. To give you an example, this is the VA system, VA ECHO. They have 11 hubs connected to more than 300 sites, but you can see the number of spokes. I think the slide is not clear, but each of these hubs has got multiple spokes coming out, connecting to scores of sites. But you'll see some of these lines go all the way across. Sometimes in Canada, you'll find that not every part of Ontario or every province has all the specialty they need. You can do cross-border. So we have a program starting in Northern Ireland soon and the Irish Republic, 3 programs there. And what we found was that in Northern Ireland, for 2 million people, they have only one pediatric endocrinologist. When she goes skiing to Switzerland, there is no pediatric endocrinologist in the country. So we're going to start a cross-border echo there between Northern Ireland and Ireland to share expertise. These are our international projects currently. In India, we have a few, and Uruguay, etc. This is our big data vision, where we want to aggregate data from across the country and the world to get insights on disease patterns, etc. This is our team. I want to recognize them by just one award they got in 2007, which was called Disruptive Innovations in Healthcare. This was an award, 307 entries from 27 countries, and this team came first in that competition. In conclusion, using multi-point video conferencing, best practice protocols, co-managing patients with case-based learning is a robust way to safely and effectively treat common complex disease in rural underserved areas and to monitor outcomes. And I hope you will use this model for hepatitis C. But Jordan and some of his colleagues have allowed us to take a few comments or questions about, I'm really interested in knowing whether you think this can work in Canada. Thank you.
So we'll take about 5 minutes or so for some questions, and while you are organizing your thoughts, I'd like to ask a question first, Dr. Arora. My question is, did you find with the primary care physicians in particular that you trained to be hepatitis C specialists, did that trickle down into an appreciation that other types of liver disease were out there, that they were treatable, and did you end up having more referrals of previously unrecognized and untreated liver disease?
That's a really great question. I think exactly that's what happened. We found that just training them on hepatitis C didn't cut it, because these people also have liver disease. So you have to train them in cirrhosis. You have to train them in diagnosis of liver cancer. You have to train them on making the diagnosis of hepatitis C, making sure the patient also doesn't have Wilson's disease, making sure many of them had hemochromatosis along with hepatitis C, and literally they became hepatologists over time. They didn't become transplant hepatologists, but they became hepatologists because they were hanging out. A man is known by the company he keeps, right? They were hanging out with hepatologists and all these people every week, and they learned more and more. Any other comments, questions? Specifically about, yes?
I have a question. So out of all of those sites that you were working with, I'm sure you had some really smashing successes and a couple of sites that maybe failed to launch. What lessons did you learn about the sites and your approach to the sites and the sites that didn't do so well that you could share with us?
You're talking about new hubs or the spokes?
Spokes. Where did it
Okay.
not work, and how can we avoid that in our own projects?
Sure. I think the spokes don't work if the leaders at the community health centers, local primary care doctors, are just only focused on making money, and they don't want to have their primary care doctor spend any time becoming an expert or learning. That's the one way the spoke fails. That's the only way the spoke can actually fail. Hubs can fail if the specialist doesn't have the interest in demonopolizing the knowledge. In the United States, the health system is organized around knowledge monopolies. You know, I do residency, fellowships, medical school, right? And then I became a super specialist. What is the current model in the United States? I sell my knowledge in piecemeal fashion. You want to talk to me for 10 minutes, it'll cost you $250. If you don't want to talk to me, you can go anywhere you want, which could be, a few hundred miles away. So guess what? Lots of people want to talk to me for that 10 minutes. And that's not echo. You have to be willing to demonopolize the knowledge. The second is the specialist running it has to have a deep respect for primary care and their contributions to medicine. If he looks down upon them and doesn't have a thoughtful, respectful, kind, demeanor on a knowledge network, it'll flop. But other than that, there isn't it's not rocket science. It's just a collaborative model of sharing knowledge, supporting each other, mentoring these primary care doctors, and it just works. You have to, of course, fix the time. It's not a random event. Hepatitis C Project ECHO occurs at 3 p.m. every Wednesday and goes till 5 p.m. every Wednesday afternoon. Everybody in New Mexico knows that. That's the time. You want to be a Hep C specialist, you block that out of your schedule, show up on your webcam, and that's how the game starts. So thanks for the question.
Sanjeev, thank you very much. Thanks so much for coming. I mean, as you know, I've been a huge fan of, since I first saw you talk about this a few years ago and seen the progress with this program, and I really do think it's almost perfect for Canada, and it's been a bit hard to get it started. So I guess maybe just one question, if you can give me an idea of, well, I've spoken to you about it before, but for the audience to just get the idea of what we do next to actually get the ball rolling to get this started.
I think that's a really important question. I think the first thing is that ECHO is a system intervention, okay? We're trying to improve the health system in Canada. That's the goal. Hepatitis C is a wonderful leading disease for it. Second, one Jordan Feld can't convince the government here to do this. That's why I said I need all your input. If you believe this is a good model for your country, you need to speak up and support. We already have one ECHO launching. It's going to launch in 6 weeks here for chronic pain in Ontario. So the data will start being collected, everything will start happening. But there is no disease like hepatitis C to launch ECHO because it'll save lives like you won't believe, basically. In the United States alone, the CDC estimated, published, showing there would be 897,000 deaths from hepatitis C. I talked about 20 million worldwide. You're talking about World War kind of mortalities, and you have effective treatment. So that's the second. But you need allies. You need a community groundswell to say, let's go for this thing. And I think the last talk I heard was a very compelling one. That needs to be given to the Ministry of Health here and the federal bodies, etc. And I think that ECHO can help in that regard, but it was not going to change people's mind if they don't believe that hepatitis C is something they want to treat. So I think we are on the right page, but you need a lot of support. And that's why I think it has been really such a good idea, for me, a good idea to come here to see if we can generate that for you.
This is incredibly exciting. From the start of your talk, I'm thinking, where did you get, how did you get to the politicians? How did you get to the people with the money and the decision making? Because that's you know, and how did you break that monopolization of knowledge?
So what happened? Thank you for that comment. I started this project as a volunteer because in the beginning it was just an idea. The next step was to get philanthropy involved. Why philanthropy? Because in the beginning there was no evidence. So philanthropy had a role in setting up the first project. So Robert Wood Johnson Foundation, General Electric Foundation, Helmsley. I mean, we have many philanthropic supporters. Once a project ECHO starts getting going, that means what I mean is if you actually have a hepatitis C ECHO going, then get government in to sit in an actual knowledge network clinic, that is extraordinarily compelling for them. They get it. They get it because they see how the system improvements are occurring, how the community. But the ideas are harder to sell. I think for you it'll be easier because we have a lot of data now, many publications, 5 publications, 6 publications, 4 or 5 in Hep C, etc., and others. But it does require, the model will sell itself once the knowledge networks go. But in the beginning, philanthropy helped us because we convinced some philanthropists and said, okay, can you help us get a pilot started? And then but it does require a little bit of a sales approach. That's what I was doing today, by the way. All right.
Hi, thank you for your presentation. Denise Thomas from First Nations Health Authority in British Columbia. As a staff member of an Indigenous organization, which is being led by community-driven models and approach, I was really impressed with the community health worker role and responsibility that was being developed. And coming from the model that you presented, which is selling the model to the community and to the primary care provider, could you talk a little bit more about the development of the new role and then also the reciprocated education in terms of cultural competency?
Thank you. That's a really important question. So it takes us to a fundamental principle. The fundamental principle in Project ECHO is task shifting. What we are saying is some of the roles of specialists can go to primary care, but that's not enough to just dump stuff on them. What are you going to take away from them, right? What will go to nurses? So you have to train a whole workforce for major public health problems of the kind we're talking about. So we trained 250 community health worker diabetes, obesity specialists. We've trained 100 community addiction recovery specialists. We trained 250 of the prison community health workers. What we find is we train these people in cohorts of 25. So we put out a call and say, we're going to train classes starting, 25 community health workers for our diabetes specialists. Of the 150 diabetes specialists, literally 75 or more are from native tribes. Why? They already have a culture of what they call community health representatives. They've been using them already. The problem with community health work worldwide is most of the trainings are what we call one and done. We train them, send them home, and then basically hope for the best. What ECHO does differently is that it is a long-term mentorship program. It's a way of not only just training them, but giving them ongoing case-based learning. As they do their work, every week they come back and say, oh, I saw this patient, he asked this question, I don't know the answer, what should I do? This is the diet, this is the weight, what's the intervention? This learning loop starts operating, and then this task shifting becomes much more effective. The second key goal in community health worker programs, which is different from all others in the world, is we are not focusing on making them generalists in everything in medicine. Not a patient educator general, but we are giving them a very deep knowledge in a very narrow area. That specialization with mentorship, it is what gives them the tools. And lastly, our most recent initiatives are to give them information technology tools. For example, each one of them will have Android devices. These devices, they can use as educational videos for patients. They can track what they do on a day-to-day basis. They can track patient outcomes like A1Cs, etc. But more importantly, these devices will make them connect to the knowledge networks by video, basically. So this combination of bringing these things together with task shifting and mentorship and support is particularly relevant for native tribes. And the cultural competence is naturally there because we only train the community health workers who are already community members living in the community. It's not like we take a community health worker from outside and plant him in First Nation. We take a First Nation high school graduate, make him a community health worker specialist. And thank you for your attention.